Hello. Okay. Time is ready. Yeah. Okay. Hello, everyone. And now we beginning the first customer Roland webinar. Today, we invited the Professor Ruifang Sui to have a lecture about easy vision electrophysiology, why and how. Yeah, the Professor Sui is from Beijing, Peking Union Medical College, College University. Yeah, college hospital. Yeah, her hospital is the #1, the general hospital in China. Yeah, it's this year is the 100th anniversary. Yeah, Professor Sui is the head of ocular genetics and vision electrophysiology division in Department of Ophthalmology. And today the lecture's objective is to tell the beginning to how to use select and read the vision electrophysiology easily. Yeah, so we make this small red book to about that the object. Yeah, you can download the PDF document from this QR code. Yeah, this from the Baidu cloud. Also, you can upload from this Zoom meeting room the chat windows. I have uploaded it. And for the beginning, the technician, I also make some the videos. I also upload to the Roland Consult the YouTube channel, and this QR code you can download this video, and this video also download this today's Zoom meeting the with chat windows. Now, let's begin to invite the Professor Sui to have the lecture. Please, I stop the. I transfer the host to the Professor Sui. Okay.
Okay, let me share my screen. Hello, everyone. I think we may in different time zones, so I may say good morning, good evening, good afternoon. Okay, it's my great pleasure today to share our experience in how to use electrophysiology to help us in diagnosis and management of eye disorders. Compared to other technology we usually used as images, looks easier, but electrophysiology is not that much difficult. It's a little bit difficult compared to imaging, but if we know the basics, it will be easy for us to use. When we mention visual electrophysiology, it's not one thing, it's a group of examinations we need to choose, we need to think. We divide our electrophysiology into ERG. It's basically when we see retinal electrogram, the key point is retinal. So we have something focused on retinal ERG, VEP, visual evoked potential, and EOG, electrooculagram. For ERG, based on the method and the portion, the location, and the simulation different, we can divide ERG into 4-field flash ERG, pattern ERG, and multifocal ERG. For VEP, we have pattern VEP, flash VEP, and multifocal VEP. And we do not have other divisions for EOG. When we mention the pattern, it means the stimulus is not flash. When we mention flash, it means the stimulus is a flash of light. For multifocal ERG or multifocal VEP, the stimulus is different, a very special pattern. All these electrophysiology examinations, we have something to follow internationally. So it's a SF standard, except the multifocal VEP. Multifocal VEP, nowadays we only use for research purpose, not for clinical evaluation. So when we do other electrophysiology examinations, we always follow the international standard. So we can compare between different labs and different locations. For electrophysiology, visual electrophysiology, it means we are measuring something different. We are not measuring the thickness of a retina. We are measuring something, it's a special the electrode can get and record it. So we will need some basic anatomy. In this picture, in this slide, we have two pictures. One is a model of our eye. In order to see something, the first tissue is a retina. When we have a light go through the cornea, the lens, and focus on the retina, where retina have a series of chemical reactions and form an electrical impulse. Our first electron impulse will formed in the photoreceptor. Our photoreceptor get the light signal and transform the light signal into an electrode signal and pass the signal to the bipolar cells, and the bipolar cells pass the signal to the ganglion cells, and the ganglion cells can transfer the electrical impulses through the nerve fibers finally to the cortex. So this part actually is a C. The retina will get something, we can see. In this process, we have some important cells. If we know what the cells are doing, we'll know if we have something impaired these cells and what disorder we will have, and we will know if we record electrophysiology, what we will have. For example, if we have a disorder make RPE and photoreceptor damaged, we can get something from the EOG. If selectively we have a disorder impair the second neuron transmission, for example, the bipolar cell transmission, we can see here the bipolar cells will contribute a lot to the B wave of our ERG. So we know we will find something important change in B wave. If we have a disorder selectively damage the ganglion cells, so we know the PERG, especially the N95 waveform, will have a change. So we need to know what the contributions of the cells to our vision, and then we'll know if we do what, if we know a disorder, we'll know the basics of the anatomy, and we'll know how to choose the right examination. In the retina part, actually it's C. We know if we have a vision, we'll have our cortex will translate the electro signals finally into something we can understand. So when we have the retina get the C and form the electrical impulse, the impulse will transform from the nerve fibers to the optic tract and go to the lateral geniculate nucleus, and finally from the radiation to the cortex. So if we have something wrong along this way, along the neuron transport way, we also can have a impaired vision, and also we can have our VEP help us to diagnose this disorder. As I mentioned, we have a lot of electrophysiology modalities. When we face a patient, we should know what kind of examinations we need to order for this patient. So we need to know what's the difference between VP, ERG, and etc. So I will give a short summary for typical cases. For example, if we have a patient with optic nerve disease, we usually choose pattern VEP and flash VEP to evaluate. If the patient have a very poor visual acuity, or if we have no waveforms by pattern VEP, we need to know if the visual cannot formed, if it's related to the optic nerve, and we have other disease need to diagnose and as a differentiation. For example, if the patient have a macular disorder, we also may not have a normal pattern VEP. So usually if we do not have a confirmed diagnosis based on a pattern VEP or flash VEP, we order a pattern ERG or multifocal ERG to exclude any retinal and macular disorder. The most difficult scenario in the clinic is if someone have a trauma and the patient may be not able to, or the patient may not want to cooperate with us. So we need to have an objective evaluation for his disease, for the trauma, and to know how severe is the trauma caused. So we need to do VEP, and usually if the VEP is non-recordable, we need to check swipe VEP to get an objective measurement of the visual acuity. Of course, visual electrophysiology is not the only examination we need to order. For the clinicians, we also need to order images. Hereditary retinopathy is a big group of retina and macular disease. In order to have a detailed conception for the disease, we always do SF standard FFERG. If the FFERG is non-recordable or if it's normal, we also need to do a pattern ERG or multifocal ERG to know if only limited cone rod left, or if the disorder is too severe, we really do not have any recording. For some disease, the patient may look normal. For example, if they are a carrier for X-linked retinopathy, we also can use ERG to find early retinal involvement. As the retina is the eye is a window of the soul. Also, we can see the retina is a window for a lot of systemic disorders. For example, hypertension, diabetic retinopathy, and a lot of immune disorders. We can have eye involvement manifested as vascular retinopathy, as arthritis, ocular artery occlusion or vein occlusion or other form of vascular retinopathy. To do visual electrophysiology will help us to know how the retina function, and also can help us give suggestions for the medical doctors, their systemic treatment. So we will choose ERG. When I say ERG, it means multifocal. It means FFERG. We will choose ERG, especially pay attention to OPS, and also if the patient have a localized disorder, for example, only the macular involvement, like AMD, will do multifocal ERG. As the anti-VEGF is a wide used treatment for vascular retinopathy and also for AMD, we can also use our electrophysiology to detect any drug side effect. Macular disease, we know, is a localized cone rod, and also cone rod may be RPE disorder. Multifocal ERG and pattern ERG is the best choice. Toxic retinopathy is, compared to other retinopathy, is rare, but sometimes it's difficult to find, so it may not that rare. For example, if a patient under a TB treatment or some immune disorders, they use steroids or clonidine, they will have early drug effects, but the visual acuity may still stay normal. So we can use electrophysiology, especially multifocal electrophysiology, to do a follow-up. So if there are any early drug effects, we can detect, and also we can report this to their physicians to adjust their treatment. For kids, go back. For kids, amblyopia is also most common manifestations if a child have a poor visual acuity, and they also have some refractory error, and if their visual acuity cannot correct it to a normal level, we always give the amblyopia as the diagnosis. In order to monitor the treatment, pattern VEP is a good choice. But if the patient are supposed as amblyopia but do not have improvement after a long time of treatment, we need to do a ERG, because they may have other retinal or optic nerve or other disease we do not know. If we do ERG, if we may find some rare hereditary retinopathy. We also can use ERG to evaluate our patient before cataract surgery, because for those older patients, especially, they may have a lot of systemic disorder, complicated retinal disorder with cataract. If we can evaluate before cataract surgery, we may know the prognosis. The patient, if they know they have limited improvement after cataract surgery, they have this in mind, so they will not be disappointed if their visual acuity improvement after surgery not as good as others. Glaucoma, we know for glaucoma we have a lot of image analysis, but for functional evaluation, pattern ERG and photopic negative response also are good for follow-up and for evaluation for their optic nerve function. We have a group of patients, they come to the clinic, but we do not have a clear clue for why they have a poor vision, why their visual acuity are lost or are not good. So if we do not have a normal, we have a normal looking fundus, but poor visual acuity, will always follow this flow chart. For example, we first do pattern VEP. If the pattern VEP is normal, we'll go details for multifocal ERG and or full field ERG. If they are normal, for example, if they are follow this arm, it maybe they are not have a real disease, they may have a functional visual loss. So we can follow the different arms, but I will not go details. Always when we have a recording, we print it out, we have a data results, but it's sometimes we do not know how to interpret the results. So I will give a explanation for how to read these waveforms. For a VEP, this is a pattern VEP. We always pay attention to first to look the waveforms to see the P100 and N95. If they are the peak time are in the, we can record it and we put the cursor in the right place. And also for each visual electrophysiology lab, we need to have our own normal value. We can see if they follow within the normal value. Also, we need to know if they are when we recording several times, they are repeatable. If they are not repeatable, it may be a false response. So we always to recording and choose the repeatable waveforms. When we also need to compare the two eyes. Sometimes, if especially one eye the visual is normal and another eye have a abnormal or diseased visual acuity, so we will compare the two eyes. Both we need to know their peaks and amplitude. If we have a normal peak, we will record them and write down the value. If we have an abnormal amplitude, we will also see how severe they decrease. If are they mild or moderate or severely decreased, and also based on our own normal limits, we will give how severely the patient amplitude are damaged. We will give these numbers. For VEP, we not only recording one check size, we always recording at least two. In our lab, we always recording 1 degree and 15 minutes, and to see if they are the visual acuity and their responses are explainable. And also sometimes for a flash VEP, we will compare the transient frequency response. If the transient frequency response are unrecordable or unrepeatable, we always see a steady state frequency response. For each lab, when we have patients, we always need to organize our patient, and also we will tell the clinicians why we need to order our patient. Sometimes the patient may need to wait sometimes relatively long times to finish all these examinations, because we want them know. For example, if we have a flash full field ERG, we need get a patient dark adaptation, a light adaptation. It takes about 15 minutes to finish these adaptations. And also we need to get a patient dilated. So if we know which step the time we need to spend, we will let the patient and the clinicians know why it takes such a long time to finish these examinations. Nowadays, we have a lot of selections for electrodes. Electrodes is a key to get a good recording. We usually, our first choice is a jet electrodes, but for some kids, they are not acceptable, and we will choose DTL. But recently we have HK loop. We evaluated HK loop. It works very good, both for kids and adults. So we are now recording some normal data, and we are trying to choose HK loop as our first choice. For some patients, and for example, for a multifocal ERT, sometimes we can choose BA electrodes, but you know, BA electrodes is kind of expensive. It depends your own lab, your choices. It's, for example, gold foil, we think it's good for pattern ERG. So it may not mean you only can use one electrode. You can choose different based on different patient and different examinations. Now I will give some examples. First, if we know, we remember a normal waveform, we can easily find the abnormal one. Let's see some normal cases first. And these are normal adults. We recorded this both 1 degree and 15 minutes pattern VEP, and we can see the noise is not big. It's a very good looking waveforms, and also they are repeatable. Both the peak time and amplitude are within normal limits. This is the normal flash VP. We can see the P2 peak time, and two waveforms are repeatable, and the amplitude are within normal limits. This is a kid. Usually, kids have a higher amplitude compared to adults. These are adults. Both are normal. This is the normal FFERG. Now we always recording 6 waveforms. This scotopic 0.01, this 3.0 and 10.0. This dark adaptive OPS, and these are light adapted 3.0 and flicker. We can see we have a very low noise, very good looking waveforms. Although I only show one waveform, but we repeated several waveforms, and they are recordable. They are repeatable, and we also gave this choose a representative waveform and print it out. This normal pattern ERG, we can see P15 and N95. Because pattern ERG, the amplitude are low, so we give a division. Is per division is 5 microvolt. Multifocal ERG. When we do multifocal ERG, we need to know we are recording this central part with retinal function. And we will know we can print both the retina view or a visual field view. And we can also put the overlay of the functional examination with our image examination. For ERG analysis, we need to print out the tracery for each point and to see the waveform. And also we can analyze by different regions or different quadrants. It depends on the disease location. And also we can have a density map. For example, this one, we print out three data form. One is the tracery, and this is the 2-dimensional, and this the 3-dimensional response density. The response density looks fancy, but we need the tracery is the key. If we do not print out the trace key, we'll miss something sometimes. This is a normal EOG printout. For EOG, we need to look this to see if the patient eye movement is normal and smooth, and we choose the dark trough and the light peak, and we will calculate, get the Ardon ratio. This is a normal one. And also we'll get a detailed real cases. As we mentioned before, VEP is always used more frequent than other electrophysiology examinations, because we have more patients with optic neuropathy. They have a painless vision loss, and sometimes we didn't see anything wrong when we examine the fundus, normal optic nerve, and sometimes we can see the optic nerve hyperemia or edema. We have different type of neuropathy, optic neuropathy. For example, it may be ischemic, or it may be demyelinating disease. It also can be some hereditary disorder. The case one is optic neuropathy. It's optic neuritis. We can see the patient have a painless vision loss, and we can see the P100 peak time decreased when we decrease compared to normals, and also the amplitude is decreased compared to the two eyes. So we can see the right eye is diseased. Compared to the demyelinating disorder, ischemic optic neuropathy always have a normal peak time, but the amplitude is abnormal. So for this patient, the left eye have ischemic optic neuropathy. But for some severe or long-lasting ischemic optic neuropathy, we also can have both the amplitude and peak time abnormal. Case 3 is optic, is a patient with a trauma. We need to do objective assessment, how severe the patient is. For this patient, we can see when we record the 1 degree pattern VEP, the amplitude is almost similar between two eyes. But when we recording the 15 minutes, we can see the left eye is severely, the amplitude is severely decreased, and the peak time also increased. So we know the patient, the left eye, the damage is get damaged, and because the 1 degree recording is normal, so we also can have a assessment, and we see the patient, the left eye visual acuity is about 0.3. So it's very important to use VEP, especially pattern VEP, to do assessment, objective assessment. I have mentioned this, so I will not go to more details for this slide. This case is a Stargardt disease, but this patient we always have patients at different stage of Stargardt disease. We know Stargardt disease, the patient can start visual acuity loss impairment, and before they are before the age of 10. In the beginning, the visual acuity maybe is mildly impaired, but with the decrease, with the progression, the disease will have by severely decreased visual acuity, also the retina involvement will spread. Not only the macula, the whole retina may be involved. This, I show you a patient we followed for 5 years. We can see the patient, the retina involvement is spreading. Also, the atrophy in the central spread. So for a patient, if we want to use the functional evaluation for their macular and retinal function, we can choose a PET ERG and FFERG. In the early stage, the PET ERG is abnormal, but the flash ERG may be normal. But in the late stage, in some patients, the different genetic mutation in the same ABCA4 gene can cause a severe phenotype or a mild phenotype. So when we have a patient with Stargardt disease, we need to follow them, and we need to use functional evaluation to know which stage are they? Are they in an early stage or are they in a severe stage? Because in different stage, if we enroll a patient into a clinical trial, functional evaluation will be more accurate if we still can recording their ERG or PET ERG. This patient, when we do a multifocal ERG, is very severely decreased. It's almost flat. But the same patient, when we do full field ERG, we may find only a change of the cone responses and only a mild increase of the implicit time. And also, when we have a patient at this stage, we will know we will have both cone and rod function impaired. This case is a cone rod dystrophy. Cone rod dystrophy sometimes is difficult to diagnose because sometimes we see if we record a patient have a OCT, macular OCT, thinning of the retina, we do not know if this patient is a macular dystrophy or is a cone rod dystrophy. We need to record FFERG. FFERG will give us a solid evidence, and we can see the patient is a cone rod dystrophy or a rod cone dystrophy or a macular dystrophy. This patient, we can see the patient have near normal dark adaptive responses, but very severely decreased cone responses. So this patient will give a diagnosis as cone dystrophy. In our clinics, we also have patients with different kind of yolk-like macular dystrophy. This vertiliform macular dystrophy can be dominant, inherited, or recessively inherited. The same gene, bestrophin gene, may mutant, and the phenotype is different. For example, this is a typical Best disease, but this one have a satellite lesions, and this one have a broken yolk and maybe dystrophic RPE. For this patient, we may have a normal FFERG, but when we record EOG, the Arden ratio always be decreased. This patient is best disease. We can see even the patient have a normal or near normal visual acuity, we can find very decreased Arden ratio. And congenital stationary night blindness, CSNB, is a group of disorder. The patient may experience night vision problem, impaired central vision, and also can have nystagmus and strabismus. It's a big group of disorder, but they have a normal visual, normal fundus. And also, if we do not record the ERG, we always will miss this group of patients. We have a wrong diagnosis. The ERG is very typical. We always will have a near flat scotopic 0.01 ERG and a negative B wave, and we'll have only one OPs. The normal VP OPs will have 4. And also we have near normal cone responses, but the A wave is big and wide. This typical complete form of CSNB. And also we have incomplete form CSNB. And for incomplete form, we also have a negative B wave, but the cone responses also will be impaired. And this is a implicit time of CSNB. When we mentioned the negative ERG, retinal schisis is also a typical B wave negative. For retinal schisis, it's an X-linked disorder. At different stage, we can see maybe only macular, the foveal schisis, and the peripheral schisis. At a late stage, the cavities will disappear and will have dystrophy, both neural retina and RPE dystrophy. This is a typical case of retinal schisis. We have a negative ERG B wave, but we can see compared to the CSNB, the A wave of cone responses is not flat. It's a sharp peak A wave. For inherited retinal dystrophy, retinitis pigmentosa will be the most common type. But even the patient who have the same diagnosis of RP, they may have different retinal phenotype. Sometimes we can see the typical bone spicules. Sometimes we can see this red and greenish dot. We see it we call it pepper and salt pigmentations, and sometimes we do not have any pigmentation at all. But we cannot judge RP only by the retina experience. We need to record ERG. For example, this patient, we can still have a recordable ERG. But for this patient, we have a non-recordable ERG. When we have a non-recordable ERG, it doesn't mean the patient do not have any vision. Maybe the patient with the non-recordable ERG but have 20/20 or 1.0 vision, because they maybe have only the central cone photoreceptors are still functioning. So for a flat ERG, we'll need to record multifocal ERG. Occult macular dystrophy is also a very tricky disorder because they will have normal looking retina, decrease the central vision. If we record ERG, flash ERG is normal. When Dr. Miyake reported occult macular dystrophy at that age, we do not have we do not have OCT at all. And nowadays, when we have very clear OCT, we can see the occult macular dystrophy actually is not occult. We can see the OZ zone is discontinued. And also the integration zone is also discontinued. And when we record multifocal ERG, we can see multifocal ERG is also abnormal. And the multifocal ERG abnormal will representatively will know which part of the macular the function and the anatomical structure is they are at, we can know this at the same stage. For the children amblyopia treatment and follow-up, pattern VEP will give us some clue. For example, the before treatment, the PERG, PVEP, the amplitude and time, peak time are abnormal. After treatment, the visual acuity improved and the pattern, the P wave, the peak time and amplitude will back to normal. I have mentioned before, sometimes we think cataract is not is easy. We can do the surgery. We do not need any functional assessment, but to avoid any misunderstanding by the patient, or we sometimes need to do prognosis evaluation. You use ERG as a functional adjustment, and to tell the patient if the cataract is the only cause of visual impairment, if they also have other retina and optic nerve abnormality, we do VEP and ERG. We can give them explanation how the visual acuity improvement after cataract. For example, for this patient, we can see their B wave is abnormal. So it's the implanting in the retinal function is not good. The visual acuity may not back to 2020 after surgery. For glaucoma, besides image analysis, we need to put functional assessment. We can use PET ERG as a good candidate method. So I have gave some examples, but the examples is typical. We also have real-time, real life. Our patients are complicated and sometimes they are untypical. This pocket book, we call it a red book, will help you to understand and to know more cases. And I think if you have any clinical difficulties, you can check this book and maybe help you to do a better job in your work. And thank you for your attention. And I think maybe we have time for questions. Thank you. That's my share. Ms. Tang, do you want to take over and give some comments or questions and answers?
Yes. Thank you, Professor C. Yeah. And everyone, if you have some question, you can input your question in the chat windows, or you can open your voice. After the webinar, I will upload this video into the Roland Consult the YouTube channel. You can review the videos, the lectures. And I have uploaded the video, the operation load video and the red book with PDF into this chat windows. You can download. Mm-hmm. Professor Sui, yeah, some question, but I don't can't understand. Yeah, have you experience in visual P 300? What means? I don't know.
Oh, unfortunately, I don't know. Is it mean P300? I don't know. VP? I don't know. Oh, it's a cognitive visual evoked potentials. No, actually, sorry, I do not have experience for this kind of VEP. And I think maybe cognitive visual evoked potential are only under research, not for clinical use. Another question I can see is CSNB and KNCV2. Yeah, for CSNB, the B wave is negative. That's the key. But for KNCV2, the scotopic 3.0 and 10.0 waveform is super normal. Which means super normal. The B wave, both the A wave and the B wave, is bigger than normal. For example, if our normal limits for B wave is 450, for a KNCV2 cases, it will be 600, 500. But the scotopic 1.01 0.01 waveform is almost flat, and the cone responses is decreased. So it's easier to differentiate CSNB and KNCV2 related cone rod dystrophy, because KNCV2 genetic defects will cause cone rod dystrophy, but with a supernormal responses for combined cone and rod recording. And also another question, can you differentiate a late presentation of ischemic? For a late stage ischemic, late and severe stage of ischemic optic neuropathy sometimes will have both decreased amplitude and increased peak time. For optic neuropathy, we also can have similar findings. But you know, when we give a diagnosis, when we try to help a clinical diagnosis, we do not only depend on visual electrophysiology recordings. We need to know the history of the disease. We also need to know other ocular examinations, for example, how's their OCT, how's their visual field. So we need to combine this to for a clinical case. For any clinical case, we do not depend only on electrophysiology. What is the VEP pattern in compressive? For a compressive optic neuropathy, for example, in a trauma, the disease is if the patient still have some vision, we will have a very decreased decreased amplitude, and sometimes we'll have a non-recordable. We do not have any response can recordable, and because the transmission, the sheath, the optic sheath is not good, and because the damage is very severe sometimes, we also have decreased amplitude plus increased transmission, increased peak time. Okay, I think we may have no more questions, and oh, okay, another question about the waveform, W form, PVP, or M form. Sometimes it's a M form, PVP. Yeah, sometimes we do have this pattern. Actually, you know, when I start our electrophysiology lab, I need some normals. I trying to be a normal to record my own PVP, and I myself is a M form or a W form. When we have this, we actually will do manually to choose the peak, and we use the elongation of the two lines and find the meeting point, and the meeting point will be the peak time, and the amplitude will be the two waveforms average. I hope I explain because I cannot I cannot draw the picture. I think you may understand this. Thank you.
Okay. Even no other question, yeah, we can finish. Yeah, thank you very much, Professor Sui. Yeah, for your excellent the lecture and the answer the questions. And yeah, also thank you for everyone to attending this lecture. Okay. Goodbye to everyone. Thank you. Bye bye.
Okay, thank you. Thank you. Bye. Bye.